bronchial passages, contributing to the ongoing inflammation. These are some of the cells that are involved in asthma. Classically, the mast cells are cells that migrate into the airways. They have little granules that contain inflammatory chemicals, IgE, and a variety of other things are involved with this. IgE will cause release of the mast cells, inflammatory mediators. Eosinophils are drawn to the airways. Eosinophils are a key cell that it's a white blood cell that's involved in inflammation and asthma most commonly. The lymphocytes, like, as Dr. Friedman has mentioned, also are involved in this interplay. There are other cells, neutrophils, and the epithelial cells themselves interact. Some of the chemical mediators that are known, histamine, leukotrienes, which we'll talk about, prostaglandins, platelet activating factor enzymes, and cytokines. Cytokines are chemicals that cause cells to act in a different fashion than one would expect sometimes. These are bronchoscopic photographs of a patient. This is pretty much normal. You can see this is the left upper lobe bronchus and the left lower lobe bronchus. You can see this little line. These are blood vessels. Normal blood vessels can be seen in the bronchial passage. This is the same patient 10 minutes after being challenged with an allergen or some trigger for asthma. You can see that the bronchial passages are markedly narrowed. There's swelling and edema of the airways, and this would lead to obvious symptoms of shortness of breath, cough, etc. Here's another picture of a similar patient with asthma. You can see the lumen of the bronchus is narrowed, edematous. There's some mucus or inflammatory cells. Just another picture of inflammation in the situation. So airway inflammation leads to most of the symptoms that we associate with asthma, including the hyperreactive airways in response to triggers, cold, dust, allergens, etc. You see airflow limitation and chronic disease if the inflammation is not checked. When discussing asthma or evaluating asthma as a physician, you have to go through a differential diagnosis to rule out other conditions. Not all that wheezes is asthma. Here we see a circle that represents patients with asthma. This is a circle that represents patients with emphysema secondary to chronic smoking, and this is a circle that represents patients with chronic bronchitis, for example. You can see that there's some asthmatic patients who do have some emphysema associated with their disease, some who overlap with chronic bronchitis, and some who have a triple whammy of all three diseases. Other illnesses need to be ruled out: laryngeal dysfunction, tumors of the vocal cord or the large airways that might produce obstruction and cause some wheezing that the patient perceives or the doctor can notice on examination. Airway remodeling is one of the ongoing hot topics in asthma research and treatment. It's very hard to measure, but one often sees in clinical practice patients who have had asthma for many years or decades who come in with pulmonary function tests, breathing tests that suggest emphysema or severe irreversible airflow obstruction. The fibrosis in the bronchial tubes occurs in some patients. We don't know which patients are susceptible to this. The fibrosis contributes to persistent airflow obstruction and limitation. In the definition of asthma, reversible airflow obstruction is really one of the hallmarks. So we're talking about advanced disease where the inflammation has gone unchecked. In the National Education protocol from the NIH, they have divided this into four major elements: measures and assessment of monitoring of asthma, control factors contributing to asthma severity, pharmacological therapy, and education.